Now next we will discuss about appendix. So appendix. Now length of appendix is, it varies from 2 to 10 centimeters. It lies around 2 centimeters from ileocecal orifice. Diameter of appendix, it ranges from 1 to 3 millimeters, which is roughly of the size of matchstick. So length of appendix, it ranges from 2 to 10 centimeters. It lies 2 centimeters distal to ileocecal orifice, and diameter of appendix is 1 to 3 millimeters, which is roughly of the size of matchstick. Now another important point is that it is located at the terminal end of cecum, where the 3 tinea join. Now if we talk about the blood supply, so it is supplied by, now talking about the blood supply, appendix is supplied by appendicular artery, which is a branch of ileocolic artery. So it is supplied by appendicular artery, which is a branch of ileocolic artery. And this ileocolic artery, it lies in the mesentery of appendix. It lies in this appendicular artery, it lies in the mesentery of appendix. Now sometimes what happens, this appendix is supplied by an accessory appendicular artery, which is called as artery of Seshachalam. Clear? Now next let us discuss the various anatomical positions of the appendix. Now next we will discuss about the various anatomical positions of appendix. Now suppose this is large bowel, this is ileocecal orifice. Now the appendix, it can be retrocecal, or it can be paracecal, or it can be pre-ileal. Then we have post-ileal. Then we have pelvic type of appendix, or it can be subcecal. So these are the various positions of appendix. Now if we label them, this is retrocecal, and retrocecal, it is the most common position of appendix. The most common position of appendix, it is retrocecal. Then this is paracecal. Then we have pre-ileal. Then this is post-ileal. Then this is pelvic and subcecal. Now one more position is there, that is subhepatic. Clear? Now the most common position, it is retrocecal, followed by pelvic. and retrocecal is present in 75% cases and pelvic in 20% cases. Now, opening of appendix into cecum is guarded by a valve which is termed as valve of Geralch. So, another important point is that opening of appendix into cecum is guarded by a valve which is termed as valve of Geralch. Now, next important topic is acute appendicitis. Now, let us discuss acute appendicitis. Now, first, let us discuss the etiology of acute appendicitis. So, first is etiology. Now, in the etiology, the first important etiological factor is dietary factors, and it has been seen then that lack of fiber diet, it increases the chances of acute appendicitis, whereas adequate intake of fiber-rich diet, it decreases the chances of acute appendicitis. Now, another important factor is obstruction, and it is obstruction of the lumen of appendix. And this obstruction can be due to fecalith, it can be due to stricture, then foreign body, then roundworm, or it can be due to threadworm. So next important point is obstruction of the lumen of the appendix, which can be due to fecalith, can be due to stricture, it can be due to foreign body or worm obstruction. Now next important etiological factor is adhesions and kinking. Adhesions and kinking, which can be due to carcinoma of cecum at the base. Carcinoma of cecum at the base of appendix can cause adhesions and kinking. Now, next important etiological factor is ileocecal Crohn's disease. Ileocecal Crohn's disease. Next etiological factor is abuse of purgatives. Abuse of purgatives. Now, sometimes what happens if there is an obstruction in the colon, it will lead to the proximal inflammation into the appendix. So, distal colonic obstruction can lead to an inflammatory pathology in the appendix, which can lead to acute appendicitis. Now, next, out of all these etiological factors, the most common cause is fecalith. Fecalith obstruction, it is the most common cause of appendicitis. Clear? Okay. Next, let us discuss the pathogenesis of acute appendicitis. Pathogenesis of acute appendicitis. Now, what happens if there is a luminal obstruction? It will cause what? It will lead to mucosal inflammation. Now, due to this mucosal inflammation, what happens? The mucosal fluid, it collects within the lumen of the appendix. Due to this mucosal inflammation, the mucosal inflammatory fluid, it collects inside the lumen. Now, collection of this inflammatory fluid, it will lead to increased intraluminal pressure within the lumen of the appendix, and which is termed as mucocele of the appendix. So, it will lead to it will lead to increased intraluminal pressure, which is termed as mucocele of appendix. Mucocele of appendix. Now after that, what will happen? Due to this increased intraluminal pressure, there will be blockage of lymphatic and venous drainage. Now once there is blockade of this lymphatic and venous drainage, what will happen? There will be edema in the wall of the appendix. So it will lead to increased edema in the mucosal wall. Now once there is edema in the mucosal wall, it can lead to ischemia and it will compromise the arterial supply, that will lead to ischemia of the wall. Now it will lead to compromised arterial supply, leading to ischemia of mucosal wall. And this ischemia will further lead to gangrene of appendix. Now once there is gangrene of appendix, what will happen? The appendix can get perforated and the perforation site can be either at the base or tip of the appendix. So gangrene of the appendix can lead to perforation of the appendix, which can be either at the tip or base of the appendix, which can lead to perforation peritonitis. It can progress to perforation peritonitis. Now, if after perforation there is localization by omentum and ileum with pus inside, it is termed as appendicular abscess. It is termed as appendicular abscess. So localization of the pus by the surrounding omentum and the ileum, it is termed as appendicular abscess, whereas if there is localization without pus, it is termed as appendicular lump. So appendicular lump, appendicular lump means localization by the greater omentum and localization by greater omentum and ileum without pus inside. It is termed as appendicular lump or appendicular mass. Now next, let us discuss the clinical features in case of acute appendicitis. Now please remember that the most common symptom in acute appendicitis is pain. Now what is the characteristic feature of this pain? The visceral pain, it starts in the periumbilical region and after few hours it shifts to the right iliac fossa as somatic pain. And this somatic pain, it occurs due to irritation of the parietal peritoneum by the inflamed appendix. So what is the most common symptom is pain, and characteristic feature of pain is that visceral pain, it starts in the periumbilical region then after few hours somatic pain, it occurs in right iliac fossa. And what is the cause of this somatic pain? It is due to irritation of parietal peritoneum. Irritation of parietal peritoneum by the inflamed appendix. Clear? Okay. Next important clinical feature is vomiting. Then patient may have fever, tachycardia, and sometimes the patient may have increased frequency of micturition, and this is due to irritation of the bladder by the inflamed appendix. Sometimes patient may have increased frequency of micturition, and this is due to irritation of bladder by inflamed appendix. Now, there are some important signs in case of acute appendicitis. Let us discuss them one by one. So, important signs. Now, first important sign is Bloomberg sign. And what is Bloomberg sign? It is tenderness and rebound tenderness in right iliac fossa at the level of McBurney's point. So, Bloomberg sign is tenderness and rebound tenderness at McBurney's point. At McBurney's point. Now another important sign is Rousing sign. Now what is this Rousing sign? On pressing the left iliac fossa, pain is felt in the right iliac fossa. So this is termed as Rousing sign. So in Rousing sign, what happens? On pressing left iliac fossa, pain is felt in right iliac fossa. And why this happens? This is due to shift of the bowel loops which irritate the parietal peritoneum. Now next important test is Baldwin's test. Now remember that this Baldwin's test, it is positive in retrocecal appendix. It is positive in retrocecal appendix. Now in this what happens? When legs of the patient they are lifted off the bed with knees in the extended position, patient complains of pain while pressing the flanks. So this is termed as Baldwin's test. Now in this test what happens? When legs are lifted off the bed with knees extended, patient complains of pain while pressing poor flanks. Now next important test is Copy-Swas test. Copy-Swas test. Now this Copy-Swas test, it is also positive in retrocecal appendix. It is positive in retrocecal appendix. Now in this, what we do, hyperextension of the right hip will cause pain in the right iliac fossa. So this is termed as Copy-Swas test. In this, what happens? Hyperextension of a right hip, it causes pain in right iliac fossa. And this pain in right iliac fossa, it is due to irritation of the psoas major muscle, and this pain is due to irritation of psoas muscle. Now next important test we have, it is obturator test. Obturator test. Now this obturator test, it is positive in pelvic appendicitis. It is positive in pelvic appendicitis. Now in this, what we do, internal rotation at the right hip joint, it will cause pain in the right iliac fossa. Why it occurs? It is due to irritation of the obturator internus muscle. So in this, what happens? In this, internal rotation at right hip, it will cause pain in right iliac fossa, and this pain is due to irritation of obturator internus muscle. Clear? Now in these patients, if we do the digital rectal examination, what we will find, there will be tenderness on the right side of the anal canal. So what we will find on digital rectal examination, there is tenderness on the right side of anal canal. Now next important sign is that there is hyperesthesia in the Sharon's triangle. Now have a look. Next is hyperesthesia in Sharon's triangle. Now what is this Sharon's triangle? Now have a look. This is anterior superior iliac spine and this is pubic symphysis. So the Sharon's triangle, boundaries of Sharon's triangle, this is Sharon's triangle. So Sharon's triangle, it is formed by anterior superior iliac spine, umbilicus and pubic symphysis. So in patients of acute appendicitis, they have hyperesthesia in the Sharon's triangle. Clear? Next, let us discuss one more important sign that is termed as Dunphy's sign. Dunphy's sign. Now, what is this Dunphy's sign? It is pain in the right iliac fossa while cuffing. So, when the patient is asked to cuff, he will have pain in the right iliac fossa. It is termed as Dunphy's sign. So, Dunphy's sign is pain in the right iliac fossa while cuffing. So these were some of the important signs which we can see in acute appendicitis.